My name is Niall Ferguson. I'm head of critical care at the University Health Network in Sinai Health in Toronto and professor in the Interdepartmental Division of Critical Care Medicine at the University of Toronto. In the next 12 minutes, we're going to talk about how I do it, ventilating a COVID-19 patient. These are my disclosures. ARDS is a heterogeneous syndrome. So is COVID-related ARDS. And in my opinion, a lot of the debate about is CARDS separate than ARDS? Not so much. A lot of the same rules apply. Here's a quick summary table of some of the early case series that came out during this pandemic. And you can see that just like many other ARDS series, compliance is variable across different case series. Plateau pressures are up and down. And the Peeps being employed are maybe a little bit higher than we might have seen in pre-pandemic case series. But overall, I think the main message for me is that the same rules apply. ARDS is a heterogeneous disease, and we have some areas of relatively normal lung and some areas of densely consolidated and atelectatic lung. And we have some patients who are highly recruitable and other patients who aren't highly recruitable, usually because they already have most of their lung open and don't need recruitment. Attempts to recruit these patients results in significant compression of the heart and potential hemodynamic compromise, as well as overstretching of alveoli that are already open. And we're seeing different presentations of patients with COVID, described here from Luciano Gattinoni and colleagues, showing two patients with similar degrees of hypoxemia, but obviously very different looking CT scans, one with a classic ARDS type of CT scan and one with relatively less opacity. But just as we saw previously, those also have been described in regular ARDS. And we know from our non-ARDS, non-COVID-19 experience that there are different phenotypes of patients who meet the syndromic definition of ARDS. Carolyn Calfee and colleagues used latent class modeling to identify two different phenotypes. One in the red line, which we could call the more hyperinflammatory class with very high levels of IL-6 and IL-8, versus a relatively hypoinflammatory kind. And the interesting thing here is that these patients had a different response to Peep. So that in the low inflammatory group, in fact, higher Peep resulted in higher mortality, whereas in the hyperinflammatory group, there's a significant reduction in mortality with the use of higher Peep. And we also know that patients respond differently in terms of oxygenation. In this secondary analysis of the LOVES trial, Ewan Gallagher showed that when patients had a improvement in oxygenation after an increase of Peep as they came onto the study, that was strongly associated with improved mortality. Whereas if their oxygenation got worse, their mortality was much higher. When Peep was kept the same or decreased, we did not see any such association there. One can try and sort out how much Peep to use and how recruitable somebody is by calculating the R to I ratio. You can plug numbers into a calculator available online at rtmaven.com. And this gives you a number where the median value was 0.5 in the initial case series. And when applied to COVID-19 patients in a case series from China, on average, they were not very recruitable in the supine position. Interestingly, once placed prone, many of them were more recruitable. So it's worth looking at this in both the supine and the prone position. Now, what about spontaneous breathing? Because a lot of our COVID-19 patients are presenting earlier on and are making strong respiratory efforts. Lots of questions remaining in general about spontaneous breathing in ARDS. And lots of controversy in the COVID-19 first wave about that we saw on the news and in the New York Times. Ventilators are killing patients. People were saying we don't need ventilators anymore. This has been from the lay press into the medical press, thinking about when is the right time to intubate a patient with COVID-19. And the argument around here comes around the concept of patient self-inflicted lung injury. We know that, at least experimentally, one can cause ventilation-induced lung injury without a ventilator, just by inducing extreme hyperventilation in sheep. This study was able to show significant severe lesions in sheep that were forced to hyperventilate by injection of salicylate into the foramen magnum, and that resulted in what looked like ventilator-induced lung injury, despite there not being a mechanical ventilator. This could also be a phenomenon caused by pendiluft, where even a normal-sized tidal volume can cause injury because it's occurring and spreading around the lung. So all the tidal volume goes to the non-dependent regions first, and then all of it goes to the dependent regions afterwards in a phenomenon called pendiluft. So really, there's arguments on both sides of how much spontaneous breathing to allow in the ARDS. On the pro side, we might prevent diaphragm atrophy, improve hemodynamics, need less sedation, and we're making progress towards liberation from the ventilator. On the other side, we worry about overdistension injury or pendiluft, causing a lot of increased lung perfusion with very negative pressures being generated by the patient. We have to worry about dysynchrony and double triggering, and expiratory muscle activation may also lead to decreased end expiratory lung volume. And some of the effect modifiers in this equation include the severity of the ARDS, how small the baby lung is, how high the patient's drive is, and how injurious the ventilator settings are. We can measure some of these efforts by using esophageal manometry, or you can even use simpler things like measuring the P.1. This nice paper from Irene Tellius showing that this is very well correlated with inspiratory efforts and has a pretty good sensitivity and specificity for ruling in or out high or very low inspiratory efforts. A final way you can check effort is a quick end expiratory exclusion maneuver, measuring the occlusion pressure. And by multiplying this by about 0.7 on average, you can have the predicted P-mus level, and you might use that as a screening test to monitor more closely. My opinion-based medicine on this is that when the X-ray looks like this and the ARDS is severe, then really you need to control breath sizes using sedation and paralysis if necessary, often higher PEEP in this setting. But when the chest X-ray looks like this and there's lots of alveoli available to contribute to ventilation, then you may tolerate larger spontaneous breaths as long as the efforts are not too extreme. And similarly, you might tolerate tidal volumes up to the upper limit of what was used in the ARDS network trial. Specifically for COVID-19, thinking about early intubation might be beneficial in patients with high drive and high risk of P-cili, but it may be harmful in patients with mild hypoxemia who don't have high respiratory drive or work or breathing. So I suggest here timely intubation, as indicated not just by saturation, but by really refractory hypoxemia or hypercapnia, and by some objective evidence of high work or breathing. For what tidal volume to set, I think there's no need to deviate from our usual 4 to 8 mils per kilogram as laid out in the ARDS network trial. But remember that does include going up to 8 mils per kilogram, especially in those who are double triggering, or if the airway pressure is decreasing below PEEP when they are making an effort. Try still keeping the plateau pressure below 30 and the driving pressure less than 14. Setting PEEP is complicated, and it may be beneficial in patients who are highly recruitable, but might be harmful in patients with low recruitability. So really, we have to individualize the level of PEEP, consider higher patients with evidence of higher potential for recruitment, which you can measure through a variety of different ways. And you should also evaluate the response to your changes in PEEP at the bedside. Prone positioning continues to be a mainstay for moderate to severe ARDS patients in general, and COVID-19 patients are no exception to that. recognizing that it does take some teamwork and planning to make this happen in a safe way, especially when there are lots of these patients. Finally, one word on ECMO. Patients may develop refractory hypoxemia or have injurious mechanics where they might benefit from ECMO. On the other hand, staffing and resource demands may limit the feasibility depending on the degree of a COVID-19 surge. So our practice has been to consider VV ECMO in patients with refractory hypoxemia, as long as one can safely do it without negatively impacting the care of other patients. My take-home points: COVID-19 ARDS is like ARDS. It's heterogeneous, and different patients will respond differently. You need to tailor PEEP to recruitability, and the impact of the spontaneous breathing during ARDS depends both on the timing and the severity of the illness. Measuring patient effort is important as an important part of that. When you're allowing spontaneous breathing, consider normalizing efforts to protect both the lung and the diaphragm. And with that, I will stop, and thank you very much.